الأشعة التشخيصية في عين شمس. والحقيقة أنا يسعدني إن احنا عودة بعد غياب، قعدنا سنتين متوقفين بسبب الكورونا، فالحمد لله أنا سعيدة إن احنا رجعنا تاني نتجمع ويعني نقول نتاج الفترة اللي فاتت دي كلها إن شاء الله يا رب تبقى حاجات كلها مفيدة ومثمرة. يسعدني وجود يعني ضيوفنا الأعزاء، أستاذة دكتورة لبنى عز العرب، أستاذ الكلينيكال أونكولوجي، والدكتور خالد تعيمة أستاذ ورئيس قسم جراحة المسالك البولية عندنا في عين شمس. والحقيقة أنا بعتبر إن وجود كلينيشنز معانا ثروة، ولأنها هي دي الحاجة اللي بتخلينا نتحسن ونفهم لغة بعض، وإزاي نتعاون سوا، وإزاي نقدر نعمل حاجة للفيوتشر وتبقى مفيدة لشغلنا وللمرضى بتوعنا. هنبتدي اول جلسه النهارده في المؤتمر، ودي اول محاضره هتقولها الدكتوره منى حاتم، الاستاذ المساعد عندنا في القسم، وهي الدكتوره منى هي مدير الوحده حاليا بالقسم عندنا. والمحاضره بتاعتها PSMA in prostate cancer F18 versus gallium 68. Good luck يا منى.
صباح الخير، ازي حضراتكم جميعا؟ كل سنه وحضراتكم طيبين، ونرحب باساتذتنا دكتور خالد ودكتوره لبنى، واساتذتي طبعا دكتوره هاله ودكتوره ميرفت ودكتوره علي. التوك بتاعتنا النهارده it will be PSMA fluorine 18 versus gallium 68. As we all know, prostate cancer is one of the most common solid tumors in men. The current standard imaging methods include transrectal ultrasound, CT, MRI, and bone scintigraphy. But since CT and MRI are morphological imaging techniques, they are often unable to depict the cancer prostate foci. Recently, the early detection of primary cancer prostate and its recurrences and mets have been significantly improved by hybrid imaging methods. It is the use of a radioligand that binds specifically to the prostate-specific membrane antigen, the PSMA. The hybrid imaging is particularly suitable for the diagnosis and therapy of cancer prostate, since malignant prostate cells express the PSMA up to 1,000 times more than healthy prostatic tissue. Thus, the PSMA provides an optimal target for diagnosis and therapy of prostate cancer lesions. Several PSMA ligands have been developed in recent years. The introduction of gallium-68 PSMA has proven high sensitivity for the detection of disseminated cancer prostate. This led to the modification of treatment at various stages of cancer prostate, ranging from initial diagnosis to treatment monitoring of castration-resistant mets. The biochemical recurrence, as we all know, after radical prostatectomy, the PSA concentrations typically decrease below the detection threshold. If the patient has undergone radical prostatectomy, the PSA level of 0.2 nanogram per milli or more is considered a biochemical recurrence. And in the setting of radiation therapy or brachytherapy, any rise of 2 nanogram per milli or more above the post-radiation nadir PSA is also called a biochemical recurrence. A narrow PSA range of 0.5 to 3.5 nanogram per milli allows optimal detection of cancer relapse after surgery. This is of high clinical relevance because within this PSA range, the PSMA PET imaging detects most relapses at a limited stage. Thus, monitoring of PSA values could be useful for accurate timing of PET imaging. When PET scans are acquired too early, tumor detection rates are typically low. When a PSMA PET scans are acquired too late, the number of patients identified at limited stage disease is low, thus limiting its value for the individual patient. The gallium-68 PSMA has a significant impact on radiotherapy planning, resulting in changes in treatment planning in over 50% of patients. But it has some pitfalls. It is expensive, it's only available via local radionuclide generators, and each generator provides only 1 or 2 elutions per day, and requires separate synthesis at different times of the day in a local radio pharmacy. And also it is rapidly excreted via the urinary tract, resulting in intense accumulation in the bladder, thus obscuring the prostate. Here is an example of a 70-year-old man presenting with a rising PSA level. As you all see, the MIP image shows a focal tracer activity in the right pelvis, and it is in the course of the right ureter. The spot view here, the pelvic MIP, clearly shows that this is a right pelvic lymph node, and this is the course of the ureter. It is clearly separate from it. And the axial fused PET-CT image clearly demonstrates the PSMA avidity in the right pelvic lymph node and the normal PSMA in the urinary tract, in the right ureter. Another case of a 72-year-old man presenting with a rising PSA level of 5 nanogram after radical prostatectomy. The axial fused image shows no obvious abnormality at initial review, but after increasing the window of the SUV max, there is a focal bulge or a focal PSMA avidity in the posterior wall of the bladder. It proved to be a local recurrence by contrast-enhanced and T2 weighted images. So it could be missed if we don't clearly depict this pitfall. PET-CT shows another activity in the urinary bladder. It could be missed if we don't clearly look in the CT images. It proved to be a soft tissue mass lesion invading the anterolateral aspect of the urinary bladder and was masked by the urinary bladder activity. Another example of a PSMA-avid sclerotic lesion in the left pubic bone that was nearly masked by the urinary bladder activity. So all these pitfalls has resulted in the development of other agents with slower urinary excretion, such as the fluorine-18. The fluorine-18 PSMA can be produced in large amounts per batch in PET cyclotron and enabling transfer to satellite centers, which is not the case in gallium-68. It has a reduced urinary excretion and high tumor to background ratios, making it highly sensitive for tiny tumor deposits in the body. It has the short half-life of gallium-68 relative to fluorine-18, where gallium-68 has 68 minutes only half-life. Fluorine-18 has 110 minutes. So this limits the ability of gallium-68 to be shipped to other imaging centers. And also compared to fluorine-18, the positron energy of gallium-68 is high, 1.9 million electron volt, reducing the theoretical maximum spatial resolution. The first generation of fluorine-18 labeled PSMA ligands, such as fluorine-18 DCFBC, suffered from high background due to slow blood clearance. This led to the introduction of a second generation compound, the fluorine-18 DCFPYL, a ligand which is characterized by fast elimination via the urinary tract. The fluorine-18 PSMA 1007 is an attractive alternative to gallium-68 PSMA. It has a radiation burden of 4.5 to 5.5 millisievert effective dose, similar to other PET tracers. Its key advantage lies in its rapid blood clearance combined with minimal urinary excretion. Both features yield clear advantages for image interpretation in local tumor assessment. And compared to other fluorine-18 labeled PSMA tracer, this PSMA 1007 provides a better interpretation of lesions adjacent to the urinary tract. But it may decrease the interpretation of skeletal lesions due to higher frequency of unspecific uptake in bone, therefore should be interpreted carefully to avoid overstaging. And one of its pitfalls, owing to its hepatobiliary excretion, a higher uptake in liver is observed with fluorine-18 PSMA 1007 compared with other PSMA-targeted tracers. Therefore, the liver mets may be missed by fluorine-18 PSMA 1007, but this may happen in late stages when rare cases of liver mets can occur. As we all see, this is the physiologic distribution of different PSMA tracer. They have an increasing hepatobiliary excretion from A to D. B is the gallium-68 that we use currently in the radiological center. This is the second generation fluorine-18, and this is the fluorine 1007. As we all see, the gallium has the least hepatobiliary excretion, while the fluorine 1007 the highest hepatobiliary excretion. But on the contrary, the gallium-68 and the second generation fluorine-18 has the highest urinary excretion. And this is the fluorine 1007 has the lowest urinary tract excretion, and it can easily depict a recurrent pelvic lymph node on the right side. So this is one of its main advantages. An important note to be borne in mind that independently from the radiolabeling with fluorine 18 or gallium-68, previous cancer therapies and low PSMA expression caused by tumor heterogeneity may be responsible for false negative PET-CT in results in some patients. The take-home message is that detection rate of fluorine PSMA is similar compared to gallium-68 PSMA, but the longer half-life and the higher injected activities of fluorine-18 PSMA tracers allow higher lesion uptake, superior clearance of the background activity, and higher quality images compared to gallium-68. Now I will show you our experience in El Demirdash University Hospital. We used the fluorine 18 PSMA 1007, which is the last generation introduced in the fluorine 18 tracers. It was established in last August. And good news that PSMA is now supported by the National Health Insurance System. We have done 11 patients since August. 5 patients came for initial assessment with elevated PSA. 6 patients came for follow-up after either radical prostatectomy or post-therapy. All patients coming for initial assessment, unfortunately, were PSMA positive. Only 2 patients coming for follow-up, either after radical prostatectomy or therapy, were PSMA negative, and the remaining 4 were PSMA positive. Here is a reminder of the TNM staging we use in our reports. T1 is clinically inapparent tumor. T2 is the tumor confined with prostate. T3, tumor extends beyond the prostatic capsule, either extracapsular extension or invasion of seminal vesicle. T4 is a tumor fixed or invading adjacent structures, such as the bladder or rectum. And N1 is a metastasis in regional lymph nodes, and M1 in distant mets, either non-regional lymph nodes or bones or other. Our first case is a male, 70 years old, known case of cancer prostate of 1 month duration. The Gleason score is 7 and PSA level is 127 nanogram per milli. As we all see from this MIP image, there is multiple areas of focal PSMA avidity, either in the pelvis or near the lungs and in the bone. This is the prostate. It shows diffuse PSMA avidity with seminal vesicle invasion. So this it will be considered T3B. There is also right external iliac and internal iliac PSMA avid lymph nodes. So this is N1. And also PSMA avid dorsal sclerotic osseous deposit. Here it is. This is M1. Also right clavicular PSMA avid osseous deposit and left supraclavicular lymph nodes. So this is also M1. So the final diagnosis, it will be T3B and N1, M1. Another case, a male patient, 74 years old, known case of cancer prostate, received radiotherapy and on hormonal therapy. He's presented by elevated PSA, 14.6 nanogram per milli. Here, the MIP image shows some PSMA avid nodules. The prostate itself shows diffuse low PSMA uptake with no PSMA avid focal lesions, so it will be considered T0. There is a PSMA avid left perirectal lymph node, so this is N1. There is also a PSMA avid right external iliac lymph node, so it is also N1. So the final diagnosis is, the final diagnosis is, there's also, so the final diagnosis is T0N1M0. The last case is a male, 58 years, known cancer prostate, presented by rising PSA after radiotherapy and hormonal treatment. The MIP image shows clear prostatic bed. However, there is an uptake in the neck and upper chest. Here is the prostate. It shows diffuse, the normal low PSMA uptake, which is considered completely normal. So the prostate is T0. There is no PSMA avid regional lymph nodes, so this is also N0. However, we found bilateral supraclavicular PSMA avidity, and there are mediastinal lymph nodes, so this will be M1. And the final diagnosis will be T0, N0, M1. And by this, we end our talk. Thank you.
Thank you, Professor Menna. Very informative,
Thank you, دكتورة لبنى.
comprehensive talk related to a very important subject related to BASM, bad CT scan. Minna, we will delay the discussion till the end of the session. Thank you. First of all, I'd like to express my gratitude for sharing this with my eminent